The first agenda in our meeting is the patch meet. The patch is a hottest topic right now in shoulder surgery. Everybody wants to use a patch, and we have a lot of patches in the market, starting from dermal patches and the braces and different types of patches. So I thought it would be a great idea to have an intricate discussion on the patches. Let's find out what each patch is made of. What is the scientific evidence of each patch? So I would like to first invite our research associate, Ms. Priyamvada, who will actually give a brief intro, a very short intro, and then this will be followed by the talk by Dr. Chin on the pitch patch.
Hello everyone. A very warm good afternoon to one and all present here. I hope you're all having an amazing time. My name is Priyamvada. I'm a research associate at Shoulder and Sports Injury Unit, Manipal Hospital, Whitefield. And today I'll be giving you an overview of the different kinds of patches that are available for treating rotator cuff injuries. But before we dive into that, let's take a quick look back at how we got to where we are today at treating rotator cuff injuries. So here's a brief history. The first ever description of rotator cuff injury was made by Alexander Munro in 1788. Later, in 1834, John G. Smith detailed several cases of torn rotator cuff tendons. The first ever reported attempt to repair a rotator cuff dates back to 1870 when Hutter performed a repair after a chronic shoulder dislocation. It was in 1978 that Naviasar and colleagues proposed the use of grafts to bridge irreparable tears. They used a freeze-dried sample of cadaveric rotator cuff graft. Over the years, several innovative approaches have emerged. For instance, Ozaki and team in 1986 tried using synthetic grafts like polyester and Teflon. Now, in more recent decades, the shift has moved towards biological scaffolds and minimally invasive options. For instance, graft jacket, that is an acellular human dermal graft. Another novel technique for management of irreparable cuff tears was put forward by Savarasi and Romeo, which provides a less invasive option to arthroplasty. They described using a biodegradable subacromial balloon spacer between the humeral head and acromion. Now, here we have a person who has a tear and he needs surgery. Now, let's look at what are the kinds of patches that are available for him. Now, types of patches and grafts can be classified into many ways. One of the ways is based on species. If the graft is obtained from the same individual, the graft is called an autograft. If it's obtained from another individual but the same species, it's called an allograft. And a different species altogether is called a xenograft. Based on source, again, they can be classified as natural, where biomaterials like collagen and alginate can be used. Synthetic biodegradable, where polycaprolactone and polylactic coglycolic acid are used as biomaterials. And synthetic non-biodegradable, where polyester, propylene, etc. are used to make the graft. Now let's take a look at some common patches and grafts available in the market today. Fascial lata graft, it's a natural autograft or allograft. Regeniten, it's a bioinductive natural xenograft. It's bioinductive because it's able to change the physiology around that area. It dissolves within time and the natural physiology of the body retains function. Then we have pitch patch, which is an entirely synthetic patch. It is non-degradable. We also have some options for dermal patches, like the one from Arthrex and Ceronics. These are natural allografts. We have BioBrace, which is a hybrid bioinductive and structural graft. It's synthetic in nature, it's degradable, and it's a xenograft. So not only is it able to have the functionality of bioinduction, but it also provides structural strength. Then we have Striker Balloon. It is not a patch, but it is a synthetic biodegradable subacromial balloon spacer. It is, as I mentioned before, it serves as an alternative in some ways. Then we have a technique called bicep smash, where the biceps is taken and attached to the area, and it is natural and obviously autograph. Thank you so much. And as we move forward today, I hope the vast expertise that we have here gives us vast perspectives. And thank you so much.
Thank you, PM, for that brief introduction. Now I'd like to invite Dr. Hemant Reddy sir, Dr. Pramod, Dr. Lenin Ligu, and Dr. Himanshu Gupta to chair the next session, please. Dr. Pramod. So now we are going to start the patch meet. It's going to be started by international faculty, Dr. Kuen Chin. He's coming from Singapore. So he'll be talking about the pitch patch technique. So Dr. Kuen Chin, sir, please come.
Hello, everyone. Thank you for inviting me to this fantastic meeting. The first time in India for me, and it's amazing. So I'm here to talk about the techniques for pitch patch. So just a bit of background of myself. I've been a consultant in London, East London, for a couple of years, but I've just recently relocated to Singapore. So my acknowledgement to Jan Loitzanger, who kindly shared the surgical illustration techniques and concepts. I've no financial conflict with any of the companies, including Kairos. So briefly, the idea of using this patch was to reinforce a tendon that we think we can repair, but we shouldn't repair in the past because of the tendon quality. So it's meant to increase the strength of the repair. The pitch patch come in two sizes, standard and large size. 90% of the time, the standard size is enough for a superior cuff. It's a synthetic material made of polyester. It's safe because it doesn't have any risk of residual animals or human DNAs or proteins that can cause foreign body reactions. It's strong. The breakdown strength is about 300 newtons. And it's made simple because there are pre-fashions holes for passing the suture across the patch. So the distance of the suture will be appropriately spaced out. And it depends on where you are. Certainly in England, it's a lot cheaper than other products. So this can be done arthroscopic or arthroscopic assisted, and it's an onlay system in the sense that the graft is onlay onto the tendon after a repair. So the prerequisite is to achieve reductions and repair of the graft. Now this is not meant to be a bridging materials. It's supposed to be reinforcing a repair that we think that we can repair, but the tendons are not so good. Often two experienced arthroscopic working together is very helpful because of the techniques involved in shuttling. But of course, I appreciate that not everyone has a good assistant, and certainly in my practice, I don't have a senior resident. Often I get a first year resident, so I've modified the technique a little bit to arthroscopic assisted. So if you look at the top left, these are the pictures again from Dr. Loitzinger, is that we have achieved a margin conversions and a double row repair of a rather complex suture, a cuff tear. Then the first step is to achieve passing sutures to the medial tendons at the muscular tendinous junctions. The important thing is to use a curved suture passes with appropriate length and distance. So I find it over the years that the ConMed Spectrum MVP has the best curvatures for me to achieve this. And I learned this, I've been struggling initially to try to put a patch in and try to get a good purchase, but until I visited Dr. Loitzinger, this is the suture passer that he used. It's cannulated, so you pass if you look at the bottom left, you can see that you pass a PDS sutures into the tendon, and then you shuttle it out through the lateral portal. So you need to pass 2 sutures, one on the anterior and one on the posterior medial cuff. Right? To achieve the one on the front, you go through the anterior portal, and then you retrieve the sutures from a lateral portal, which you should put a passport cannula or any cannula of large aperture, because it's the lateral portal that you're going to shuttle your graft in. So this is an animation. So after achieving a double row repair, you pass 2 sutures, one on the medial and one on the anterior and one on the posterior of the medial muscular tendinous junctions. These are the 5 portals that we will use: posterior viewing, ASL, anterior, and the Wilmington. So after we've done the front one, we shutter the PDS sutures through the medial side. As you can see, there are 2 sutures. So these sutures will be coming out from the anterior portal, and this will be from the lateral portal. Then we pass it again in the middle pictures. Then finally, we shutter the graft in. We can use a coher or a kingfisher to fold the graft, and then we deliver into the passport cannula. There's one important tips for this is that when you do the posterior, when you do the posterior sutures, it's easier to use the suture passer to pass into the tendon. It's easier. It's easier to pass the sutures into the medial tendon via the Wilmington portal. Via the Wilmington portal. And once that's done, you shuttle your posterior sutures out from the posterior portal whilst viewing from the front. This will give you an easier line of pull. So this is the animation again. You prepare the graft outside the patients. Once you take the 2 sutures out from the cannula, you tie a knot over the medial patch, and then you prepare 2 more separate patch on the lateral hose. Once that's done, this suture, as I said, from the posterior viewing portal, the standard posterior viewing portal, rather than from the Wilmington. You use the Wilmington to pass the suture, but then you retrieve it from the posterior so that you get a better line of pull. So once you have both of them in, you shutter them into the tissue, into the shoulder. So once this is in, you tie the knots like so. Use a suture knot pusher, tie it down, and then once that's achieved, you take the lateral side, you put it onto a knotless anchor, and insert as a lateral row, like so. And this is the final construct. After once you put you tie the medial side down and put the lateral side with the double row, with the knotless anchor down, you are left with 3 holes: the purple one and the orange one. You need to pass them separately, and again, using this suture passer is very helpful. It has the correct curvatures and length. And the little tips I have learned from Dr. Lloyd Zinger is that you put this tip next to the hole, and then you simply move your suture passer slightly to the side, and you will get a nice pass, and it will go through these holes very, very easily. This is a pre-fashion hose, and you'll be surprised when you use this. It's so easy, and once you pass through the tendon, it will just find its way into this hole. Then again, we use the PDS to shuttle the suture down. We tie it down with a knot pusher, we cut the sutures, and this is the final construct. This is not easy because you will be passing sutures, shuttling them. So you need a good assistant who can hold the camera for you or shuttle and take the suture out for you. It's a 2-person job. If you have a good fellows or a very senior resident, it's okay. In my practice, I find it very difficult to find one. So I do it in a slightly different way, from an SDR inspired way. The way I do them is that I use a first pass suture passer. It's big enough for me to purchase the medial side of the muscular tendinous junction. I pass them as a mattress 3 times. So I got 3 sutures on the medial side. Then I put 2 knotless anchor into the greater tuberosity, pass them through the cuff again. I take all of them out, and I tie them outside the patients onto the graft, and I shutter them down. Tie the knots as how Dr. Lloyd Zinger showed it. But on the lateral side, they are all pre-filled. So you just sandwich them into a split bridge fashion and tie them down. This gives me a slightly better compression of the graft, in my thoughts. This is a picture of how it can be done. So the last bit of this I prefer to do via a mini open. And you can see it's essentially the size of 2 Langenbeck. This way, when I pass the 2 lateral anchors in, I know it's easy to put in, and it saves me some time because I really don't have a good residence to show me the area, clean it up, and allow me to put anchors in. It can also be used in trauma situation. This gentleman has a fracture of the greater tuberosity where he has a previous cuff repair. So after fixing that, I reinforce it with a graft. These are the evidence. This is a paper from Dr. Lloyd Zinger for 52 months follow-up, PET 2 and 3 tests. Retear rates of only 14%. One patient has a remover of the graft because of constant clicking. Significant constant score improvements as usual. From this patient where the graft was removed, you can see these are the fibers. The white colors are artifacts from the suture fixation. But you can see the growth of the fibrosites, ingrowth around the fibers. This is the intraoperative pictures before Dr. Lloyd Zinger removed the patch. And after removing the patch, you can see the heel tendon on the bottom.
Dr. Chin, sorry to interrupt. The time is up.
Yeah,
so if you can finish up fast, would be great.
Yeah, this is the last 2 slides. This is a result from another team, and again they shows the similar results of only on a small 15 group patients. They show only 3 failures and a 30% of a Sugaya grade 5, 50% tear, partial tears on the repair of the tendon. Thank you very much.
We can have 2 questions, sir, and then we'll go on to the next talk.
We'll keep the questions to the last.
We can finish up, sir. Now it's 2 questions and just 2 questions.
Dr. Chin,
Yes, hi.
do you recommend it for an irreparable cuff, or all the cuffs have to be repaired?
They were repairable cuff. So they are cuff that we can repair, but in the past we think we shouldn't repair because of the poor quality, fatty infiltration, retractions, and on the MRI you see the signal changes. They are really edematous, and you know that when you pull this down. The reason why I changed to this graft, it was because I had a lot of medial row failures when I do a split bridge. And I start realizing that I need to protect them beyond the split bridge. So I put a graft medial to the muscular tendinous junction.
How much of the load sharing happens between the patch and the graft and the tendon?
I do not know the actual data of this, but I knew that clinically they do quite well.
If you say you are crossing the medial, you are crossing beyond the lateral row, that means you are load sharing.
That's what I was trying to achieve with my techniques, the open techniques. It not just that it goes through the cuff, it goes through the patch, and then we compress it down with the 2 lateral rows, as you can see from the last slides. Whereas with Dr. Lloyd Zinger's technique, it was literally laying onto the graft, onto the tendon.
Thank you very much, Doc.